All right, can we turn on the house lights for a moment? We're going to get a little awkward here with some difficult conversations, some awkward conversations. So I want to do something awkward to begin with, which actually has tremendous benefit. Just take 20 seconds, turn to the person next to you, even if you know them, introduce yourself, tell them where you're from, what you do. I'll wait. Go ahead. Thank you, guys. Thank you for doing that. Let's talk about scripting your least favorite conversations. What are our least favorite conversations? Probably everyone's got their own list, but some of the common ones: delivering bad news, navigating upset patients, telling patients no. Oh, yeah, we do that a lot. Maybe we don't even realize it. So let's focus on that last one as we talk about scripting. Telling patients no. What are the scenarios where this happens? An opioid refill. A non-emergent study, somebody wants an MRI for a chronic condition, which, yeah, maybe it's indicated, but not from the ED. Well, I want it now. Alas. Dispo discordance. You want to send someone home, they very much want to be admitted. Or antibiotics for a URI. Oh, it's like a guttural ugh right there. Why script these? Why script these conversations? Save energy, shift endurance, and to get it right nearly every time, especially when you're tired. You know, it's like it can be hard to have these conversations, go beautifully at the end of your shift when your patience is low. And if you find yourself having the same conversation over and over and over again, it is just ripe for a framework. And think about another place where you create these frameworks in dictations or in documentation. You do the same thing over and over, so you make it a framework so you don't have to keep repeating it. Once you have a script, iterate and practice what goes well, what doesn't go well. So let's script around a case just to see what this could look like. So a patient comes in, they want antibiotics for their cold. What's our refrain? Hey, you have a virus. Antibiotics aren't going to work. In fact, they'll probably harm you. You'll get diarrhea, megacolon, you'll explode. All bad things will happen. There'll be a public health emergency. We deliver all this great logic. What do they hear? We've just laid out this logic. What do they hear? No. But what they really hear is no, 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 no. And we think like, well, I'm going to triple down, quadruple down with facts. Facts don't do so well with emotion. So I'm going to present you with two frameworks to address this situation. And one of them, we could call it yes, no, yes. And the other, let's call it that's exactly right. Now, these are frameworks. They're more of here's how you could create your own script, because my script will be different than yours because, you try to do my thing. It's like, that doesn't feel right coming out. That's why you experiment. And all of these are predicated on the idea that you listen, that you don't dismiss the patient, that you validate. So let's talk about yes, no, yes. So what we're doing here, right? We're saying no to patients. We're saying, nope, you're not going to get Z-Pak for your cold. You're not going to get, I refuse. I refuse to give it to you. I wish I had a splash zone for the front row. But really, the first thing that is going to happen with this no is a yes. And that yes is what matters to you. Right? That's the foundation of the no. What is it you're saying yes to? So in this case, it might be, hey, I want to do no harm, and I want to satisfy myself that I'm, doing the right thing. And really, if you want to go deeper, that yes sets the purpose. That's the foundation of your purpose. So first, yes. And then, no. And we say no to the issue, not the person. Because when you say no to the person, you are incorrect. Ooh, that's judgmental. If you say no to the question or the issue, well, that's more discerning. So try to avoid you in favor of the. You're incorrect thinking antibiotics will work for this versus the idea that antibiotics help for this, really common, but it's just not the case. And then you finish up with a yes. You don't just leave them high and dry. Yes is your alternate plan. So you've got your yes to what matters to you, your no, not going to do it, and then yes, here's what I've found works. Let's do this. At the bedside, it might look thusly. Your internal yes, somebody wants antibiotics for their cold. Well, what's my internal yes? Do no harm. How's this come out externally? Hey, good news. Doesn't look like a bacterial infection or anything serious. And then no, to the issue. And then validate, like, yeah, I know this has gotten better for you with a Z-Pak in the past. Well, social proof. So many patients have that experience, but what I see is those who do and don't get them have the same outcome, and those that do get them, ooh, side effects, lots of them. And then yes, with compassion, like, oh, I know it sucks having a cold, but the Z-Pak's not going to help, but here's what I'd like to do with an alternate plan. Now, I think like, yes, the script is amazing, it's amazing. You know, you're going to get pushback. Maybe 97.8% of the time. So, with pushback, set firm boundaries and lead them to acceptance with kindness and compassion, to wit. So you're not going to write me for antibiotics? Oh, I hear you. I know this can be frustrating. It's a common question I get every day, and to the best of our knowledge, antibiotics do more harm than good. But I always feel better with antibiotics. Here's the crux of it. I'm sure you do. I think it probably would have gotten better without them. This might be different than what your doctor saw last time, but for this, antibiotics aren't going to help. So in that situation, we had the special knowledge. That was, you don't have to play. That was, I know the stuff, you don't know the stuff, and I'm going to foist it upon you and educate you. Oh, I'm glad you like it. No Z-Pak for you. With this approach, the special knowledge, they have the special knowledge, and that special knowledge is what brought them to the ED. And how do you know you've gotten to that point? It's when they say something like, that's exactly right. All right, so you've had a cough and congestion for the last 3 days. How can I help you? I can't be sick. I need an antibiotic. So with the previous one, all right, how am I going to say no to this patient? But I want to get to this point of understanding where they're coming from. Tell me more. My daughter's getting married in 2 weeks, and I cannot miss the wedding. So you're worried that if you don't get antibiotics now, you'll miss the wedding. Oh, yeah, I'm not missing the wedding, but I can't be sick. So you're thinking that an antibiotic will make you feel better and not be contagious. Boom, that's exactly right. Got it. Let's do your exam. The patient feels heard. You have uncovered their special knowledge, and you've addressed their fear and anxiety and their reason for coming, which is now addressed. You won't be contagious in 2 weeks, but you might still be coughing. An antibiotic won't change that. Let's wrap this up. And you know what? I have to say, I've been watching all the talks, and I've been doing this for a long time. I never know exactly what to say at the end, so I'm just going to experiment with something new. We'll see how it goes. Make a framework for these common conversations and experiment and see what works for you. When you say no, just realize you are dealing with emotion. And when you triple down on facts and let me pull out this study and this recommendation and the choosing wiser, doesn't work so well with emotion. For difficult and recurrent conversations, make a framework. Your brain, your body, your career, and your patients will thank you. So keep on rocking.